Tilda, the male contraceptive jab, by far the most requested thing over the past week or so, and I can completely understand why. There has been a lot of publicity around this, and pretty much all of it has been wrong. And that statement applies to pretty much every side of this. The general mainstream media has taken the findings of this paper and blown it out of all proportion, and applied levels of agency to the test subjects that they simply don't have in regards to how a clinical trial is run, and then often misinterpreting the results and the findings. And then we have people from the self-proclaimed rationalist side of the spectrum on the internets. You know, those people who are all about the evidence and the research and the logics and the reason, making statements about this paper which are factually inaccurate and in some cases completely disproven or entirely contradicted by the actual paper. So today, in this video, we're going to be breaking this down into a nice, delightful little two-parter. The first half of this video, we're going to be looking at the actual research, so that you have a good, solid understanding of what is actually going on here. And then we're going to look at some of the hilarious media backlash to it. Okay? Okay. Let's do this. Efficacy and safety of an injectable combination hormonal contraceptive for men. By all of these people. Fortunately, this being a fairly standard paper, it contains a very convenient TLDR, so we're going to read that, and then I'll take you through the more choice and important parts of the actual paper itself. Context: the development of a safe and effective reversible method of male contraception is still an unmet need. The objective is the evaluation of suppression of spermatogenesis and contraceptive protection by co-administered injections of progestogen and testosterone. The design and setting is a prospective multi-center study across 10 study centers. Participants in this study are all healthy men aged 18 to 45 and their 18 to 38-year-old female partners, both of whom have no known fertility problems. Intervention, which is how the drug is being administered in this case, is an intramuscular injection of 200 mg norethisterone enanthate combined with 1,000 mg testosterone undecanoate, administered every 8 weeks. Main outcome measures are the suppression of spermatogenesis by ejaculate analysis and contraceptive protection by pregnancy rate. Basically counting sperm and seeing how many people got pregnant. A quick look at the results shows us that of 320 participants, 95.9 of the 100 continuing users were suppressed to a sperm concentration less than or equal to 1 million per milliliter within 24 weeks. During the efficacy phase of up to 56 weeks, 4 pregnancies did occur among the partners of 226 male participants, with the rate of 1.57 per 100 continuing users. The cumulative reversibility of suppression of spermatogenesis after 52 weeks of recovery was 94.8%. The most common adverse effects experienced were acne, injection site pain, increased libido, and mood disorders. Following the recommendations of an external safety review committee, the recruitment and hormone injections were terminated early. This point in itself already blows out of the water some of the media narratives that we've seen, that it was the men who withdrew from the trial who caused it to be shut down. That decision was made by an external safety committee. Conclusions: the study regimen led to near-complete and reversible suppression of spermatogenesis. The contraceptive efficacy was relatively good compared with other reversible methods available for men. The frequency of mild to moderate mood disorders were relatively high. A statement which really needs to be highlighted because, again, another popular narrative which I have seen around this study is that a lot of the mood disorders were severe, and they really were not. We'll be looking at the exact numbers shortly. And there's actually something really interesting about the mood disorders, given the fact that this study took place across 10 study centers. And I'll highlight that point when we get there. So let's really get into the meat of this, shall we? I'll skip over the introduction since it's kind of a lot of preamble waffle which isn't really necessary to the actual study itself. It just highlights that injectable contraceptives for men aren't really a thing, and that there's been some studies done along these lines before, and they had varying degrees of success. a fairly standard paper introduction. The primary and secondary objectives I think have already been covered with the introduction which I have just read. Every 8 weeks up to 26 weeks they get a jab, and then the level of contraceptive protection is measured up to 56 weeks after. And they're looking at the ability to maintain the suppression of spermatogenesis. In this instance, they're looking for concentrations of 1 million per milliliter or less, and they're testing the reversibility of it. Pretty common sense stuff. So we're going to look at the study design, and this is the first really, really important thing which a lot of people seem to have missed about this study. A prospective Phase 2 single-arm multi-center study design was applied. And then there's the mandatory legal jargon about how it's in line with certain guidelines. By far, the most important word and number in that entire paragraph is Phase 2. You might be asking, why is Phase 2 particularly important? Excellent question. It's because clinical trials are done across 5 phases. Phase 0 is the first phase, and that's the first in-human trial. It's basically a microdosing stage where you give people really, really, really small amounts of whatever drug it is that you're attempting to manufacture. And you're looking to just gather some preliminary data about the agent's pharmacokinetics, which is just a really fancy word for what the body does to the drug. How it interacts with it, how it processes it, how it gets rid of it, so on and so forth. There's no concern about the safety or the effectiveness of the drug at this time because the dose is too small to have any of those effects. You're basically just testing whether or not the body processes it as intended. Phase 1 is next, which is a slightly larger group but generally fairly small, usually less than 100 people. You're continuing your observation of the pharmacokinetics, which is how the body is going to process it. You introduce elements of pharmacovigilance, which is how safe the drug is, and pharmacodynamics, which is how the drug actually affects the body. This phase is normally done in a clinic where the subjects can be observed full time. So it's basically the first outing for the drug proper. The types of Phase 1 will vary according to what drug you're testing and how specifically you want the study to be designed. Phase 2, which is what this study is at, done typically on groups between 100 and 300, although they can be a little bit bigger. It basically continues and expands upon the Phase 1 research. You're looking at how well the drug works, how safe it is, and this is where you're going to start looking at things like genetic testing, any major toxic effects, things like that. And again, there's different kinds of Phase 2 depending on what exactly it is that you're doing. After that, if you're successful, you go on to Phase 3. This is where you get into the proper randomized, controlled, blind testing. This is basically the point where it's unanimously proved whether or not your drug does what it says it does and how well it does it, and what the real limitations of it are. And a lot of food and drug agencies like the FDA normally expect you to have at least 2 Phase 3 clinical trials before they'll even really consider releasing your stuff to the market. And Phase 4 is basically entirely pharmacovigilance. It's watching the markets, it's watching the effect of the drug once it's been sold, basically ongoing safety surveillance of your product once it's actually out in the big wide world. So that should your product suddenly become ineffective because whatever it was treating has become immune to it, in the case of an antibiotic, you then know that you need to take it back to the drawing board, alter it, and re-release. And this entire process, start to finish, can take anywhere from about 10 to 20 years. So that was a super brief rundown of all of the phases. Now you can see why the fact that this drug being in Phase 2 is important. It means that this treatment is basically only about halfway through its development cycle. There's going to need to be other studies done on this method of treatment before it even goes on to Phase 3, and from there it's going to need at least 2 rounds, probably even more than that. So we're looking at something that is not going to come to the market anytime soon. Which is why I find it really, really bizarre that, again, a lot of the hype that we've been seeing around this, a lot of the media attention has been around, oh, it has some negative side effects, men just need to man up and deal with it. No, these phases are here for a reason. Sure, some companies do try to rush their drugs through research phases, and some other drugs attempt to pressure organizations to let them go to the market, like Agi. But as we've seen, that tends to have really, really bad effects. But social and political pressure can actually influence this process. We'll come to that a little bit later, not only in regards to the female libido drug Agi, but also in regards to the female combined pill, which we'll be looking at later, because the market and research today is very different to how it was several decades ago when that came out. So I think the study at a glance that we read at the beginning of this paper has given us a good enough idea of how exactly this is going to go. All the participants were deemed to be normal and healthy upon entering. Specifically for the male volunteers, they were required to have normal reproductive function, which means a sperm count of anywhere from 15 million to 39 million, and this had to be produced across 2 semen samples with no gross abnormalities to sperm motility or morphology, and complete normal gonad function and testosterone levels. And of course they were screened for STDs and had a prostate examination done as well, to help eliminate any real confounding variables, or certainly reduce them. The males obviously also required a clear psychiatric record, just to make it easier to work out whether or not any mood changes were caused by the treatment. For the ladies, all that was required was to be healthy and of a normal reproductive state, to not be pregnant at the time of entry, and to not object should they become pregnant. Rules for the couples is to be in a stable, mutually monogamous relationship of at least 1 year, and to have a coital frequency of twice per week on average. They were also required to be reasonably sure that they would be able to remain within their relationship for the duration of the study. All pretty standard stuff. So the participant follow-up, just a quick little look-see for those who are interested. After they completed the screening, the males entered the suppression phase, which is where they get 2 gluteal injections every 8 weeks for up to 4 injection visits. During this time, the couples are instructed to use non-hormonal contraception, things like condoms, and the males provided semen samples after 8 and 12 weeks in the suppression phase, and then every 2 weeks throughout the remainder of the suppression phase, until they meet the criterion for entry into the efficacy phase. So once the guys have produced samples of 1 million count or less, they are then into the efficacy phase, at which point they are told to rely only upon the injections as a form of contraception. After the efficacy phase is over, they enter the recovery stage, wherein they're going to provide a semen sample every 4 weeks until their sperm reaches the normal range again, and they go back into using non-hormonal forms of contraception. The recovery phase was continued up to 52 weeks. So again, all pretty simple stuff, but I feel it's nice to have a fairly comprehensive understanding of it. So with all of that out of the way, let's really dig into the gold, shall we? The results. The primary objective was, of course, the suppression of spermatogenesis. Of the 320 participants who received at least 1 injection, 274 suppressed to a sperm concentration less than or equal to 1 million per milliliter by the end of 24 weeks, with a rate of 95.9 per 100 continuing users, or the 95%. There were no significant differences of cumulative sperm suppression rates by ethnic group at the end of the suppression phase. During the efficacy phase, 4 pregnancies, 3 delivered and 1 terminated, occurred among the partners of the 266 male participants, with a rate of 1.57 per 100. Pretty good result. All the pregnancies occurred before the 16th week of the efficacy phase. 3 of the 4 participants had a sperm concentration less than or equal to 1 million per milliliter, and the 4th of them had a sperm concentration of only 0.2 million per milliliter. So let this serve as a reminder to you, even if you have a really low sperm count, you can still impregnate someone. But as these results show, the likelihood is significantly less. The secondary objectives, which was maintaining the low sperm count and then the recovery of spermatogenesis. 6 men exhibited sperm rebound during the 56-week efficacy phase. 3 men had a sperm rebound with repeated sperm concentrations of more than 1 million per milliliter at the first injection visit in the efficacy phase, 2 men at the second injection visit in the efficacy phase, and 1 at the third injection in the efficacy phase. Sperm concentrations at injection visits with sperm rebound ranged from 2 up to 16.6 million. So basically, a lot of men responded very quickly, but as you can see, there were a few people for whom it took a little bit longer for this treatment to take effect. And rather interestingly, this was noted about the recovery. 8 participants had not recovered to meet the criteria of return to fertility after 52 weeks in recovery phase. the last visit accorded to the study protocol. These participants were followed on a case-by-case basis until they regained normal sperm counts, which was 5 of them up to week 74, and in the case of 2 people, it did decline further. 1 volunteer did not recover within 4 years since his last injection. So out of all of the people who went through this, 2 people declined follow-up, which means we don't know whether or not they came back up to their regular sperm count. They may have done, they may not have done. There's no way of finding out. Only 1 single volunteer did not recover within 4 years since his last injection. So despite what some people may be saying, there is only 1 person who has not recovered their full sperm count. And also, despite what some people may be telling you, this person has not been made sterile by the treatment. His sperm count is simply still below the 1 million threshold. And as we saw previously from the pregnancy section, a person with below a 1 million sperm count can still impregnate someone. His chances of doing so are just severely reduced. So anyone telling you that anyone has been made sterile either hasn't read the study or is lying to you, and anyone telling you that it's more than 1 person either hasn't read the study or is lying to you. I'm going to skip most of the part about the hormones since that's only really of interest to the people actually running the clinical trials, although I will highlight this last part of the final paragraph on the matter. Although the luteinizing hormone and testosterone were still significantly decreased at the last measurements in the recovery phase, estradiol and follicle-stimulating hormone levels were statistically indistinguishable from the baseline levels. So for the most part, people's hormonal levels did respond back to the original level during the recovery phase. However, there is this lingering problem with the luteinizing and testosterone levels being decreased at the last measurement. Now, the problem with this is, because that was the last measurement, there's no way of knowing whether or not this was a permanent shift or whether this returned to the normal level long after the recovery phase. But keep in mind, the recovery phase was 52 weeks. So at this point in time, it's difficult to say whether or not this is going to be a lasting effect. However, given what we know about testosterone injection from things like recreational bodybuilding, it is fairly well known that if you do continually inject testosterone, your body's ability to produce it does diminish. Some people recover from that, some don't, so it's kind of early days to say definitively whether or not this is really a thing. But it is something to highlight. But remember, this is only a Phase 2 trial, so this is something which is going to be more closely scrutinized and worked on in later tests. Now on to the big league part that's been causing all of the controversy: A&Es and discontinuation of injection. During the course of the trial, 1,491 adverse effects were reported by the male participants. 38.8 of these were assessed as being not related to the study products. Going to say that again because this is something which seems to again have passed by quite a lot of people. 40% of them had nothing to do with this treatment. Nearly half. Just something that I really think people need to recognize. Not all adverse effects which happen in clinical testing are as a result of the thing that you're testing. And in this instance, 40% of the adverse effects were not caused by this treatment. So if anyone's waving a 1,400 or 1,500 number at you and trying to tell you that's all of the adverse effects, they either haven't read the study or are lying to you. Table 2, which we'll look at shortly, summarizes the AEs that were assessed as being possibly, probably, or definitely related to use of the study products, and that were reported at least 5 times. The number of participants reporting these events and relation to study products as judged by the investigators, and the severity. 31% of the AEs listed were considered possibly related, 40% probably related, and 29% definitely related. 91% of all of these AEs were classified as mild, and 99% were considered mild or moderate. So there's a lot of stuff to take home there. 30% of the AEs listed are possibly related, so that's nearly a third of them, which is, maybe, could be, who knows. 40% of them is kind of a coin toss whether it is or not, and then 29%, less than a third, is definitely caused by the treatment. And then the more important part here, 91% of all of the AEs are classified as mild. 99% were mild or moderate. The overwhelming majority of the side effects of this are mild, which is the category of absolute least concern. Basically meaning that it's not really an issue at all. That leaves you with 8% which are moderate, which means they could potentially be a problem later on, and by the remaining mathematics, 1% are considered severe, meaning they are absolutely definitely a problem and will probably require some sort of intervention to deal with them. So anyone telling you that there is a myriad of super-duper severe side effects to this either hasn't read the study or is lying to you. The AEs determined as product-related were not unexpected, had been previously reported after progestogen and testosterone administration, and were noted on the study consent form as possible side effects. So most of the side effects which actually were related to this medication were fully expected. There was nothing that kind of sprung up out of the blue. And this is where things get a little bit interesting. 62 of the 65 reported emotional disorders were reported at one centre in Indonesia, with all of the AEs at this centre rated mild. Similarly, reports of increases in injection site pain and myalgia were primarily reported by men of the Indonesian centre, 69 of the 103 for injection site pain and 65 of 71 for myalgia. Increased libido reports were also high at the Indonesian centre, 63 of 124, and the Chilean centre, 34 of 124, with 100% Indonesia and 73.5% of Chile classified as mild. The number of reports of acne was high, 147, but these were distributed among the centres. The Indian centre reported very few adverse effects. Now this is very, very interesting to me. People who are blowing the emotional disorders out of the water saying, oh, it caused depression and all of this sort of stuff, the overwhelming majority of them came from one place, which raises some very, very interesting questions about what exactly is happening in Indonesia, because it seems like that particular symptom is more or less controlled and isolated in that one place, which raises all sorts of very interesting questions. Did the Indonesian centre somehow mess up the administration of the drug? Was it not mixed correctly? Was it not administered correctly? Was there something about the centre that caused it to not come out right, say contamination of the equipment used? Is there something else going on? Is there some sort of particular social thing going on in Indonesia which makes people in Indonesia more likely to have emotional disorders? Another interesting thing to consider is because a lot of these centres are dotted all around the world, they're all from different countries, is there a genetic component here? We know that things like estrogen, progesterone, testosterone, these hormones have different resting rates within populations. That is, the bell curve peaks are at different points, with certain ethnic groups having higher base levels of testosterone on average than others. So that raises a very, very interesting question about being Indonesian. Is there something about the genetics of your average Indonesianer that might cause an increase in testosterone or progestogen to have some sort of emotional effect upon them that doesn't happen to other genetic populations? Is there something about their native production of these hormones, or is there a certain gene that's more prevalent within Indonesia that reacts with it? Who knows? This is something which is going to have to be followed up on in other studies to begin to work out why Indonesia was such an anomaly in this particular regard. And now on to the really, really big one. As we all know, and it was highly publicized, there was one death by suicide in this trial. And every time I hear someone say something along the lines of, he killed himself because he was sterile, or nobody knows whether he killed himself because of the trial, or nobody knows whether it was related or not, I cringe, because this study tells you in black and white what happened. There was one death by suicide in the efficacy phase that was assessed as not related to the study regimen. The participant received 3 injections and committed suicide 1 month after the last injection. The family indicated that he could not cope with his academic pressure. So this participant, rather unfortunately, did not make it to the recovery phase. So there is no way he could possibly have known whether or not he was going to be one of those people left with permanently low sperm count. Anyone who tells you that this person killed themselves because they were permanently damaged by this therapy either hasn't read the study or is lying to you. Anyone who tells you that this was in any way related to this treatment either hasn't read the study or is lying to you. Going further, there were other non-fatal serious AEs. One was a case of depression, which was assessed as probably related. There was one case of intentional paracetamol overdose, assessed as possibly related, so we don't know whether this person did it because of some emotional problem brought on by the treatment. There was also one case of tachycardia, that was during the recovery phase, and there were 10 other serious AEs which were assessed as not being related to the study regimen. 20 men discontinued the study due to product-related side effects. Of those 20, 6 discontinued only for changes in mood, 6 men discontinued for the following single reasons: acne, pain or panic at the first injection, palpitations, hypertension, and erectile dysfunction. 8 men discontinued for more than one side effect, including multiple reasons related to changes in mood. And this is kind of important. 20 men discontinued the study, 20 out of over 300, a number which sounds really out of place when you consider some of the media backlash, which talks about how the entire study was discontinued because men couldn't handle the side effects. As you can see, it was in fact a vast minority of men who opted out. Anyone who is telling you that this study was discontinued because men just couldn't man up and deal with what women deal with when they take the pill either hasn't read the study or is lying to you. Taking a quick look at Table 2 here will at a glance give you pretty much everything which I've just told you in brief. I'd just like you to take a moment to look at that severe column on the far right, a total of 8 side effects classed as severe. So, just again to highlight, anyone who is telling you that there are loads of really severe reactions or side effects to this hasn't read this, hasn't understood it, or is a liar. By far the overwhelming majority of all of these cases are fairly mild. And as you can see, only a few of these cases are definitely related. Some, as I said earlier, are probable, but there's a good number of them which are just kind of, possible maybe. And looking at the raw numbers to the left, the majority of these cases were acne at 147, which was one of those probable side effects, and actually one of the side effects which was basically predicted, because testosterone, that's what it does when you inject people with it. And as you can see, the emotional disorders, which as we found out were mostly localized to the Indonesian center, are really quite small in number compared to everything else, and they're only possibly or probably related. Very few of them are definitely related. So it would be quite interesting to me to look at this table if you removed the Indonesian center, and then actually tried to work out what specifically it was about the Indonesian center or Indonesia itself which caused that area to have such a heavily localized cluster of mood disorders. But as I said at the start of this video, this is only a Phase 2 trial, so there's plenty of time to investigate that sort of stuff later. As the study does go on to say, as noted, there appeared to be study site differences in the number of adverse effect reports, including those AEs related to change in mood, sexual interest, and injection site pain. Although these AEs were not unexpected, particularly injection site pain with a multiple injection dosing regimen, the frequency of the mood disorders at the Indonesian center, for example, was unusually high, as compared with reports of similar AEs from earlier studies. These are considered real differences given the uniformity of study instruments, AE forms, and training of all investigators. it cannot be excluded that some of the AE reported on mood could be due to levels of serum testosterone below the reference range for some participants, at least at the end of the injection intervals after the first TU plus NET-EN injections. However, the lack of placebo-treated control group and the different time points in the suppression phase for assessment of AE and serum hormones respectively does not allow for the appropriate statistical analysis in this study. The still low levels of luteinizing hormone and testosterone at the end of the recovery phase might be due to the prolonged terminal elimination half-life of the progestogen preparation used in this study. Due to the complexity of pharmacokinetics of testosterone and progestogen levels and their interaction, it might be that a modified injection schedule for TU and NET-EN administration could lead to fewer adverse effects, especially on mood, in future studies on hormonal male contraception. So as I pointed out earlier, there's a few interesting questions about some of the more anomalous results in this particular study. But also, as I've mentioned, it's phase 2. That's the entire point of this level of study. You're starting to find out a few of the little kinks here, and now they bear investigation. You're just going to have to wait until the next study is done. And despite what various media sources might be telling you about this treatment being discontinued, well, that's an outright lie. Despite the various AEs and clinically intensive study regimen, male participants and their partners found this combination to be highly acceptable at the end of the trial, even after being made aware of the early termination of the study intervention. More than 75% reported being at least satisfied with the method and willing to use this method if available, which supports further development of this approach. This multi-center clinical study, the first large-scale multi-country trial of a combination regimen of testosterone and progestogen to investigate contraceptive efficacy in men, provides an important reference for future efficacy and safety trials of male contraception. Such trials are urgently required to enable full assessment of the potential of this approach to new contraceptive product development. So despite what some people might be telling you, actually the majority of people found this treatment to work, and they actually were quite happy with the results. And this study is the first stepping stone on a very, very long road to getting a product like this into further development studies and hopefully to the market in the next decade. Anyone who is telling you that this treatment and this approach has been put by the wayside either hasn't read this study or is lying to you. This study is the foundation for future work, and it's a very, very promising one thus far. This is honestly right up there along with Vassal Gel, which was another highly successful male contraceptive, which consists of a liquid polymer injected into the vas deferens, which basically just blocks the sperm tube in the testicles, preventing sperm from being ejaculated. And this can be flushed out at any time with another injection, and had a success rate of, I believe, 95%. And Vassal Gel, it should be noted, is another product that is currently in clinical trial. So let's consider some of the stupidity that came out of the media about this. Well, the unfunny comedian Michelle Wolf quipped that men are little bitches because a few of them pulled out of the study. Of course, as we found out from actually reading the study, as opposed to turning it into a chance to rant and rave about our anti-male confirmation bias, it was only 20 men who withdrew, leaving the overwhelming majority of men to actually complete the trial and say that they were completely happy with the result. Others took a slightly different tack. Yes, contraceptives have side effects, and it's time for men to put up with them too. Apparently, women can have such ailments as depression and acne thrust upon them for the greater good of preventing an unwanted pregnancy, but the same level of discomfort cannot be expected of men. So, of course, male birth control has become a women's issue, because everything is a women's issue, as we all well know from when feminists got to weigh in on the reproductive debate. Is the male pill good for women? The bigger issue behind the development of a contraceptive pill for men is that women risk losing control of conception. A male contraceptive pill will soon be here, but do women really want it? That is the beginning of a ridiculously cringy article wherein a woman laments over the fact that men might actually have some control over reproduction in the future. Because apparently the power of reproduction needs to rest solely in the hands of women, because reasons. Something which I'd like to point out here, just before we wrap this video up, is political pressure on medicine. Recently, I have done a several-part video series spanning numerous months following a drug called Agi. This is a drug colloquially known as the female Viagra, even though it works nothing like Viagra. It claims to raise their libido. However, in reality, it does no such thing and comes with a myriad of adverse effects, ranging from the mild and mundane, such as headaches, to making women black out. And yet this drug still went to the market because feminist and women's rights organizations pressured the FDA to allow it onto the market with accusations of sexism if they didn't do it. So feminists got women a drug which has basically no actual effect and is incredibly dangerous. Now, it's very important to think of that in the context of the female birth control pill. Female birth control pills came out in the 1960s. It was a very big part of the free love and women's liberation movements which were happening at around the same time. Coincidentally, at that time, the FDA and various other drug management bodies had significantly less and very different regulations to what they have now. Things were a lot more lax at that time, and because of the various political movements surrounding women's liberation and women's reproductive control was very much a part of that, there was a lot of political pressure to put drugs onto the market that could allow women to control reproduction. As a result, around that time, there were a lot of drugs which made it onto the market, which weren't very effective and were incredibly dangerous. Anyone who was around at the time will remember thalidomide. I'll leave a link to a page of information about that particular drug. That's something which went to the market, and long story short, only 40% of the children who took it survived. So wrapping this back around to the example of Agi and political effect, as I was saying, in the 1960s, there was a lot of political pressure from feminist and women's organization groups to get some sort of pill on the market so that women could control reproduction. And in the more lax testing environments that they had back then, this led to pills getting onto the market which were downright dangerous. For example, the birth control pill Enovid, which received reports, 132, of blood clots and 11 cases of death. It was a birth control drug which, by today's standards, wouldn't have been allowed anywhere near the market, and yet it was put there because of political pressure from feminist and women's rights organizations. As we've seen with Agi, these political organizations can put a lot of pressure on organizations like the FDA and get things brought to the market which are dangerous. These women talking about how, oh, it's men's turn to have to put up with all of these side effects of birth control, I fear that many of them may be missing the actual reality, that a lot of them are experiencing adverse effect from their pills because their drugs were rushed to the market because of political pressure to have them. We saw it happen several decades ago, and we've seen it happen this year with Agi. If women want to get drugs that don't give them adverse effects, they need to stop playing the sexism card in order to get things rushed to the market that are not ready for consumption. Not demand that men's equivalents get rushed to the market so that they can enjoy substandard products as well. It's not an issue of sexism, it's not an issue of misogyny. It's an issue of feminist and women's rights organizations putting pressure on organizations like the FDA to give them things. things, and then, fools that they are, they capitulate. And then inevitably in the following years there's all of the complaints of misogyny and sexism because the pills aren't perfect. These people who are saying these things, these feminists and women's rights organizations, really need to understand that these are problems of their own creation. They put pressure on pharmaceutical companies to invent a pill. They put pressure on drug management bodies to allow them onto the market. Then they get all of the side effects of drugs which are rushed in their development. And then they complain that it's everyone else's fault. And then when a similar product comes up for men, and the men all say, you know what, we can wait another 10 years until it's perfected, that suddenly becomes sexism. It's honestly like these people have no sense of history whatsoever. But there you go. Now you know all of the cool stuff that there is to know about this male birth control treatment.